With those words, I would like to hand this over to Dr. Vidhur Mahajan to take this conversation forward. Thank you so much.
Thank you so much, Siddhartha, and thank you, Amit, Tav, and Kiran, for agreeing to do this, and thank you to everyone who's joined. You guys are the reason these webinars become successful. We are hoping for a lot of discussion, some degree of debate today also. So everyone who's joined, feel free to keep posting your questions using the Q&A feature that you probably see somewhere here. Or feel free to write questions in the comments bar. We are very lucky today to have Amit, whose company runs a lot of clinical trials across the country. They have a lot of dashboards. A lot of data is input into their organization. Clubbed with someone like Kiran, who's helping develop what is called the National Health Stack, or has developed, in fact, the National Health Stack, where all of this data, how does it come into a standardized format? How do citizens use it? And then maybe more importantly, how do guys like Tav Pritesh, who analyze all of this data, how do they use everything that is produced by this hospital layer? Before we dive deeper exactly into data and its role in COVID, I'd request each of the panelists to quickly take a couple of minutes, tell a little bit about their work in the data analytics space as it relates to COVID, and any thoughts that they have, and then we'll dive into further Q&A. Amit, we'll start with you.
Thank you, Vidhur, and very good afternoon, everyone. Vidhur, am I audible?
Yes, absolutely.
Great. Very good afternoon, everyone, and it's a pleasure to speak to all of you. First of all, let me also share, apart from the introduction, Siddharth said that I'm privileged to be a governing council member of NatHealth as well. And for those of you who do not fully know what NatHealth is about, it's an August forum for thought leadership, as well as a congregation of healthcare leaders from across different industries, working very closely, not only with the government, but now I can see that there's been a lot of initiatives being done on the current COVID situation, right down from the national to the state levels. Vidhur, you are, so just in terms of what we do, I think Vidhur, you mentioned we are a global organization headquartered in the US, and we have a sizable India presence as well. We have close to 13,000 people in India who work primarily with healthcare organizations, payers, providers, life sciences companies, with hospitals. And some of our work is what we call as human data science, which literally means working through for better patient outcomes. So we do a lot of work in the clinical trial space. We do a lot of data modeling and data analytics.
So Amit, sorry, I'll just quick question on that. Like, out of the 13,000 people, how many of them, like how many are doctors, how many are data scientists, how many acquire data? Like, could you give like a brief, because that's a huge number, right? 13,000 people just in one organization.
No, it's a good mix, Vidhur, of doctors. So we have a large number of doctors. In fact, we are one of the largest employers of doctors outside of health systems, which runs into 4 digits. We have statisticians, health economists, and a fair amount of data scientists. We also have our own AI/ML center for healthcare, which we've launched in Kochi to run certification programs for AI and ML. So we service the global network from here, as well as service our India clients.
Nice. So there are data scientists in India that train others outside the country on AI and machine learning.
And we do a fair amount of work for our global clients as well, sitting on.
Nice. That's something to be very proud of. Cool. So Amit, what's IQVIA been up to during COVID, or like during #COVID times?
Well, I think the time has been quite demanding for us, Vidhur, because as a data organization, I think we owe it even more to our clients to actually be on top of the trends that we had been offering them and giving them on an ongoing basis. And the need for data has become even more. As we service our life sciences and medical device clients, the need for data on how the supply chain has been moving has become much more. The need for data around how hospitals have been seeing patients, what kind of disease progression is happening, and how the care journey has shifted as a result of the COVID situation has become even more. I think one big piece where India plays a huge role is India is the pharmacy to the world in a way, right? And a big supplier of generics. And it has a lot of cross-border trade flows on APIs. And some of the work we've been doing is really understanding how the situation over a period of time could play, and where could there be potential shortages, and where could there be certain things that we need to do. I think that's been one. I think the other piece, of course, given the work we do in the clinical landscape, we've been working very closely with different governments on supporting their initiatives, whether it's sizing or forecasting disease progression, whether it's working or creating matching trial platforms. In some countries, we've created what is called a care registry, which is really a registry for patients for tracking symptoms and outcomes related to COVID. So we've been fairly busy with those.
No, amazing. That's, and the thing I'll take away from that, maybe everyone will, is that clinical is one type of data, but there's the whole supply chain data also, because I think all of us who are running businesses or that depend on any kind of consumables did experience the whole supply chain disruption to a huge degree, with materials being left not delivered on time. So that's very interesting. That's one of the things that IQVIA also does. I'll move to Tav now. Tav, could you give a brief on the work you've been doing at IIIT during COVID? I know you've been on the front page of a few newspapers and stuff like that. So quick.
Sure. Thank you. First of all, thank you, Vidhur. It's a pleasure to be here, and good afternoon, everyone. So our lab at IIIT Delhi is focused on developing research methods to analyze data. And during this COVID time, I think all of that came together to really help us make some generate some evidence from data. So a lot of work that we have been doing has revolved around learning policy from data, and that includes learning policy from a conglomerate of data, for example, socioeconomic, GDP, and including data which we consider as paradata, along with COVID data, to understand what are the key interventions that we could be making and what are the key influences.
What was the term, Tav, you just used? Paradata.
Paradata, yes. So basically, all the data that could be used together with the main data in question, which is COVID. So that's one line of work that we've been doing, and some of that work was focused on understanding, for example, what could explain the discrepant burden of COVID across the world. I mean, we've been talking about BCG, we've been talking about tuberculosis, we've been talking about some sort of protection that we may have. So including all these data sets together, combining them with the real on-ground numbers that we have, and making machine learning models to see where lies the real influencer in the network, so to say, is one line of work. Then with the government, we have been engaged in building communication channels. For example, a work that we had initiated used machine learning to deliver the right information to the right people at the right time in the right format, which we called Watch Karo, and that was using machine learning to convert. I mean, first to match what WHO said with what's with all that information out there, to fish out what is information from misinformation, and then to deliver it in bite-sized Hindi audios. So that was a local language effort that we had done. So then forecasting models for COVID, ICU, usage, etc. That's another line of work that.
So, Tav, amongst all this work, like what would you say has been the most well received, or has been most impactful out of all of these multiple projects that you mentioned?
So, well, I think impact, if you look at different phases of the epidemic require different strategies. So at the beginning of the epidemic, you require a strong messaging system in place. So that's when you need people to be aware of what to do, and I mean, you need people to be aware right now as well. But there's a role of every technology at the right moment. So when it started out, I think our Wash Karo work was received with a lot of it received a lot of attention as well. Users who really liked it, because, and we did some impact analysis as well. How are the women versus men looking at Wash Karo in the languages that we had, for example, supplied, and from the standpoint of, we wanted to reach out to the people who needed the information the most. So they may not be educated enough. They may not. So that was the, and they may like to listen to news instead of WHO bulletins, and then look at what. So at that phase of the epidemic, Wash Karo was the most impactful. So as we progressed, the projections became more important. How much would we need? How much ICU supplies would we need? And the supply chain, as you said. And I think at some point of time, looking at the public sentiment, doing analytics upon not just sentiment but emotions, that are we, so the role of panic in the bulletins versus what happens on Twitter space. So I think at every point of time, each of these has had a role, and going forward, we keep innovating, I think, in the directions as they come up.
No, thanks. That's super insightful. We'll come back to all of this. Kiran, what have you been up to? I'm sure you've had plenty of sleepless nights as well at iSpirit. But what have you guys been up to in the last 3 months or so?
So I'll talk a bit about some of the work that the National Health Authority got pulled in on the COVID period. So we still run the good portion of the 1075 helpline, which is the national helpline for COVID. So had to do a lot of technology work there, because almost all the people who work on these call centers had to work from home, and then we wanted to collect data about what's going on. So we had to pull out systems that these people who are answering these calls could actually work on their phones, take the calls in, at the end of the call actually fill everything back on the phone, so that actually we could then start getting data back from what was happening that could then be used to assist.
So this is for whom? This is for for Ayushman Bharat beneficiaries, or this is for anyone?
5 is the helpline that's been fairly well advertised during the COVID period. So it originally started as the NCDC helpline. So and then there was a capacity requirement, and so many organizations got roped in, and it was led by the National Health Authority in terms of most of the volume was actually picked up by the National Health Authority. And in states where they had capacity, we started routing the calls back into the state call centers. But then there were some technology layers that had to be delivered to make sure that we could see and understand what was going on as people called, because it's one of the, you could say, lead indicators of information that was coming. The other area that we actually got involved in was actually with symptom reporting on Arogya Setu. So, a whole bunch of people in different areas were reporting, saying, I'm having these symptoms. And so we ran a fairly large program to, I think we touched more than 7 lakh people who claimed that they had symptoms, to actually filter out which were the real ones, and then had a process to kind of get the district surveillance teams to actually go look at these problems. And this is when it was still the initial, the numbers were far lower than today, when this was actually very important, because contact tracing at that point was a super important part of it. So that was another.
But Kiran, how does that happen? Like literally, many of us, we've been reading about, whether, let's take the Arogya Setu example, right? So we've been reading about how amazing it is, and how, how seamless it is and all of that. But I'm sure it has a lot of blood and sweat behind it, right? So can you give us?
I have some insights, but not too much, because I'm not I wasn't a core part of the core Arogya Setu team, and we were
or let's say the telephone helpline, right? Like can you describe what exactly happens, right? Like one is to say that, okay, we got people to work from their homes, but like from a pure technology standpoint, what is it that you did?
So I mean, 2 or 3 things, right? So you needed first to move from most of these people where the whole technology stack that we had, right, was for these physical call centers where these call center people actually come and work on a desktop.
Yeah, just to clarify my question, Kiran, the reason I'm pushing on this is because I'm sure a lot of our audience is fairly technical in nature, given the title that we give. So that's why.
No, not a problem at all.
Yeah.
So the first and foremost thing is that we had to shift to a cloud telephony solution, because the way the calls get routed, they land on a certain PRI which is going into an office's EPABX. So you had to reroute it so that you moved it into something we call a cloud telephony. Then we had to get all these agents' numbers plugged into the cloud telephony so that now you could still route calls to their mobile numbers.
Mm-hmm.
And then you needed to give them a different kind of a CRM that they could see on their phone. They could trigger the next call on their phone. After the call ended, they have to fill out something called a disposition, which they then do on the phone. And then you get the data back into a central system, which you then do it. And of course, you have to wire that up in about 5 days. So, and then make sure that you handled all the pain with all of the people who were trying to use the new system.
Nice. And how many agents, like how many call center agents?
We were at about 900 plus agents.
Wow. Amazing. Nice.
Yeah. Cool. So I think that's 2 parts of what's been going on. Plus the government has been, as you're aware, there has been this about 2.5 years ago, about August 2018 was the first vision paper from NITI Aayog on the thing called the National Health Stack, which is the digital framework, which we call it the digital building blocks that can actually help streamline the flow of health data across both private and public. And so the government's been working towards accelerating that. So the Honorable Finance Minister announced the the approval of the National Digital Health Mission, which is the organization that's supposed to implement the National Health Stack. So that happened as part of the economic package. And quite recently, there's been a lot of action in government to make sure that that starts up and gets kicking in. And and we can talk a bit more during this webinar as to what kind of benefits might it bring, because I think across state governments and across government, right, there's been a lot of push on technology for a variety of things, right, from starting from what town needs, like how many cases came, how many went positive, where are they from, what can I know about first contacts with them, what can I predict from that, to how many beds and how many ventilators do we have, and how many people are on those beds, and when did that bed get empty, and when is the where is it going to get freed up, right? So to all these people coming in, many states are doing very extensive home quarantining. How do I know this guy is not leaving his home and walking out? How many people do I chase, and how do I actually monitor? So I think in many ways, technology has been pushed to the front as state governments and governments scramble to kind of figure out how do I actually manage for this jurisdiction or this administrative area that I have, what technology can help me actually do a better job in handling COVID. And so I think we have seen a lot of, and of course, it's given that there is a lot of state-specific initiatives, we have seen a wide variety of different initiatives and stuff across states. So I've been part of a few of that and that's been keeping me busy too.
Nice. You've been keeping quite busy.
Can I come in here, Vidhur?
Please, of course. Amit.
See, Vidhur, I think, from the India perspective, we need to keep 3 things in mind, right? When to the point Kiran is mentioning. One is India is a country of 30 countries, right? In a way. Each state, each micro city, and when we look at some of the data movement, we have seen some startling statistics that don't make sense, because some states have behaved very differently from others, right? And I'm not even getting to the reasons. So one is that. So, you have to keep that in mind when you're designing something. Now, second thing is, please understand when you look at data, and I'm coming back to data, the mindset of data has till now a lot of been post-mortem. Let us look at data that is in history and let's try and understand some trends from there to make some judgments about the future. But what has happened today? You are actually pushed into a scenario where you need as real-time data as possible, right? And add to that, the complexity of a disconnected system compared to many other parts of the world with 10 to 15 times the population. So when you add all of these three things, and I'm emphasizing with Kiran's position, right? There's no solution or there's no ready framework. I mean, it has to be so dynamic, especially in India's context, to keep coming and figuring out how you tune the strategy as you go forward.
No, that in fact, Amit, thanks for bringing that up, because that's what I was going to ask you, is that, is there any example of a country that has successfully used data to its advantage? Because it seems like everyone suffered, right? Of course, people are now talking about the Taiwan model, and but in either Amit, you or anyone can actually take this question. Like, what is an example of a COVID success that has been driven by either availability or analytics of data?
I mean, it's very, Vidhur, I would find it very unfair to compare India's situation to any others. But if you look at the countries which have worked through at least the first phase of containing it, and we don't know what's going to go forward, I think it's been at the back of very aggressive testing and contact tracing. It's been at the back of very, very strict enforcement of quarantines, right? And it's been at the back of availability of a huge available public health infrastructure. So for example, I remember Switzerland opened up way before their schools and offices because they had the available beds and hospitals per population is way more than many other countries. So they were less worried that even if people are contacted with this disease, they'll be able to take care of them. But only the countries which could manage very aggressive contact tracing and containment are the countries that managed to flatten it sooner than the others.
So does that mean that data may not have played that big a part, or would that, because like you rightly said, there is no past data for COVID, right? We only have real-time data for COVID. So can one consider it to be like an equalizer across countries, wherein it's not necessarily reliance on historical data, but ability to gather, analyze, and act as fast as possible that can drive success?
So Vidhur, look, I think what has played a role as an influencer is the connectedness of the system and the ability for you to pull out data on a timely basis, right? I mean, today, if you look at countries where your health systems are not connected or automated, or if people are not voluntarily sharing that data, how will you get it? So that's one point, right? I think the other point is people have used that data. So if you look at some countries who are now doing basically checking for antibodies, right? So there are some countries who move to that phase where we're trying to understand whether herd immunity is building up or not. So they are using data and analytics to a large extent. I think we are in a phase where, obviously, given the expanse of our country, we took a long time to even get the data pieces together. And that's still work in progress, very openly, right? And I couldn't have seen it any other way, Vidhur, in the complex system as ours, to actually get public, private health systems data. And I believe, it's a watershed moment. Let me share some statistics with you. Since we do so much of analysis, see, the March, April, May, June, each phase has been a different phase in this whole COVID timeline, right? I'm talking about the broader spectrum, right? So March was the initial implementation of lockdown. There were a lot of unknown variables. There was a complete freezing of the supply chain, right? April was when the whole lockdown was actually implemented. And people, when we see what happened as a result of that, a lot of people were at homes, their habits changed. Hospitals and doctors were not practicing, right? May, some of these things started opening up. And one of the things which then started to play out was what has been the impact of what was locked for 1.5 months. When it opens, how do you see the movements happening, right? And there are some interesting trends from that. Now, where the question becomes from here onwards, and my sense is that we are still seeing certain states moving into a trajectory where the peak is still away, right? Of what is called a theoretical peak. And each may reach a different point of time. So to me, in India, data plays a huge role, because learning from some states and understanding how this will move or manifest will help other states contain whatever load they may have if they were not acting on those points.
Got it. No, that makes perfect sense. Kiran, you have something to say on the? Sorry, Tav, please.
Yeah. So, so I think data is the only tool in the arsenal that we have for any country, that holds true for any country. So when we are talking about the role of analytics, I think if we clearly define analytics as descriptive, predictive, and prescriptive, I think we have been in the phase of descriptive analytics so far, where whatever data we see emerge, we take some policy actions on the basis of that. From there on, to get onto the predictive analytics is something that I think a lot of people around the globe have embarked upon. And if your question probably is actually towards that, the HME models or whatever models, how much have they actually helped in guiding policy? I would say still somewhat guidance. I mean, all models are wrong, and that's a very famous statistical notion that all models are wrong, but some models are useful. And we did some work, and the title of that was that building less wrong COVID models with transparent assumptions. But the idea is that we can still make some headway with predictions. But when it comes to prescriptive analytics, actually guiding policy with analytics, that's something I don't think has happened anywhere around the globe. But underneath all these three kinds, data is the only tool that we have, even if we want to do contact tracing or do testing. I think without data, it's pretty hard to even imagine what the scenario on the ground could be.
No, that's very insightful, and especially the thought around policy driven or data driven policy. The fact that the whole world is kind of evolving right now, and we've seen retractions in NEJM and Lancet to the extent that one would have never imagined pre-COVID. Is very interesting. Kiran, do you have something to add to the connectivity bit that Amit mentioned, or just general thoughts?
No, I think Amit's absolutely right. Wherever you see such fragmented levels of healthcare or in the way it's delivered, it is a real struggle to, I think, build systems that can reliably give you data. And I think your output is as good as the quality of your inputs. And if you can't trust the quality of your inputs, you're always going to be questioning what you actually built your whole model on. And I think that's definitely a challenge. So one of the things, the other bit apart from this is actually access to data. What are the policies and how do governments view access to data? Do we really believe in and implement open data policies? Because it's not that data is not available. Sitting sometimes on the other side in government, I do see that there is actually a lot of data, which many times there may not be the ability to actually take up or analyze, but the appropriate enabling policies that can make it available to a wider ecosystem that could then actually contribute more effectively is also not fully in place. And so that's also quite a bit of a challenge, and especially in the health sector, I think it's as much a challenge as anywhere. And I think these kind of fault lines show up more strongly during periods like COVID, because when the COVID period started, and I think most of us went into lockdown, everybody wants to help the government. So, the number of people banging on government's door saying, I want to help is pretty high. But then the ability for government to actually respond to that and actually leverage is also fairly limited because of policies and other things kind of being there. So one of the things that we are trying to kind of make sure happens with the National Digital Health Mission is the clarity of these two policies on how will personal health data or completely personally identifiable health data be handled. That anyway is coming largely under the Personal Data Protection Bill, and the bill has provisions for regulations that would be specific to healthcare. Non-personal data is actually, the government has formed a committee under Shri Chris Gopalakrishnan. That committee's feedback is pending, but we are hopeful that once that comes out, similar to what happened on the personal data protection bill, there'll be a lot more clarity on this whole, non-personal data and open data in some sense. But I do believe in one of the things that should happen with the stack is open data stream to a lot more on health that will become a lot more available with clearer policies. It's one of the clear tasks or asks of what's going to happen. So, and second, if the framework is in place, you could trust the data a bit more, simply because it would ensure that you're putting in something in place, even in a fragmented or even in a care delivery system like India, because the stack is being designed for Indian conditions to handle the, the large, the small, and the middle kind of, all kinds of different kinds of players and providers that come in, are very active in the Indian market. So you should be able to trust that data a bit more. So I'm really looking forward to seeing how that rolls out and how well it's accepted across different providers as it plays out.
I'm glad, Kiran, that you brought about this policy enablement side of the whole data story, right? Because we started in our lab testing for COVID-19 about a month ago, doing the whole RT-PCR testing bit, and it's only now that we realize the extent of data that ICMR actually has about each test that is done. And as individual labs, we can literally download like our entire janam patri of COVID testing, if I may. But then again, can I download Lal Path Labs results, and even without the patient name and patient identifier, and then, or not me, but can Tapritesh download that? I think those are the difficult questions, and the earlier they get answered, we get better insights. Let's take some of the questions that have come up. I'll just go in chronological order. The first one is from Krishnendu. The question is for Amit and Tav. Seeing the demand surge in PPEs and healthcare services, should India look towards a medical supply chain consortium? Very interesting, like what the WHO initiated as UN's COVID-19 supply chain consortium. So any of you three, if you have any thoughts on this, like should India look towards a medical, I don't even know what that means actually, a supply chain consortium. If you guys have any thoughts.
Amit, do you want to go first?
Yeah, let me attempt this. So look, Krishnendu, I think the question is absolutely valid, and I do know that there were two issues that were there. One was the issue of people really not understanding where is the demand versus supply and availability. And the other was there were lots of lacuna and gaps initially in delivery and import and everything else. So to me, the medical supply chain consortium will only solve part of the problem. I don't think it's much needed, but I think the building the standards, having a clear procurement criteria, making sure that there is a logistics highway that is cleared, are all things that need to be thought about. So my view is that this is definitely needed, but I think more is needed beyond this. Over to you, Tav.
Yeah. So my view there is that I see this as a part of the bigger challenge that we have, and that challenge is, as Kiran was saying, is about connecting. So I think wherever coordinated response is needed, and that coordination could be between supply chain factors and or healthcare factors, I think what we should be looking at, and supply chain is one part of it, is how do we create that backbone, and the National Health Stack's role is actually towards that. But how do we operationalize that across different sectors in which supply chain is one part? I think if we can start imagining that and start taking action towards that, that would be a great starting point. But yes, you're right. Having a consortium of just the supply chain could have definitely helped, and probably could have made a lot of things easier, made more timely. Their availability could have been made more timely. So yes, that's a great use case, so to say,
Yeah.
for
that's and I think for what it's worth, just the economic shock itself incentivized people to connect to each other, maybe in unstructured ways rather than
Right.
so like we've all seen WhatsApp groups of suppliers and buyers and all sorts of things happening in the month of April, primarily where the biggest demand supply shock was. We'll quickly head to the next question. Very interesting. I think this person has read your work, Tav. Could Tav give an example of what kinds of paradata proved to be useful while building AI tools for COVID-19? Is panic from sentiment analysis one such example? This is from Vishnu Subramaniam.
Yeah, thanks, Vishnu, for that question. I think no, so panic or the emotion analysis could be one form of paradata, but the ones that we were looking at more specifically were more healthcare related. For example, the Global Burden of Disease study from IHME that actually has indicators on countries, and even within the country there are indicators available on things like how well is the country performing in terms of water sanitation hygiene, on tuberculosis and vaccination and BCG and things like that. So a lot of indicators and neonatal mortality, etc. So a lot of these indicators were recently being thought to play a role. For example, hygiene hypothesis. So there was a discussion that maybe India is seeing less deaths because perhaps our immune system is more primed. Right, so that's when we brought in these paradata together with the number of cases that were happening and the rate of change of these number of cases, the trajectory, how many days from 100 to 1,000, and so on and so forth. And we did a model, I mean, a joint multivariate model to detangle some of these effects. So that was one example, and we did find weak evidence for maybe the role of hygiene hypothesis that could be playing out. So that's a more I would say standard data definition of paradata. But you're right. I mean, nothing prevents us from including social media data as paradata in models.
Got it. Thanks for that, Tav. I think we can club the next two questions, and guys, feel free to chime in. So Vivek has asked this along with an anonymous attendee. What about the timeliness of reporting data? We keep learning regarding poor adherence to reporting timeliness. I think this is maybe along the testing. A lot of the media did cover that aspect of either lack or delay in reporting of testing data, as well as its accuracy. Doesn't that hurt in respect to generating appropriate responses? And then the next question is, whose job is it to actually collate this data, right? Who is at fault if it doesn't really come in at the correct time with correct accuracy and then in the correct format? I wonder, Kiran, if you want to take this, because converting unstructured data to structured is kind of what the health stack is all about.
Well, I think timeliness was also hurt for sure. Is I think still being hurt, and you should realize also it's because of if you take, and I think I just heard you say that your lab started doing tests this one ago, so you would have noticed that you're probably reporting to both ICMR through the system that they've given and also to the state government.
Correct.
In
Correct.
some way. So generally, labs would have taken precedence of reporting to the state government first before they went out and filled on the ICMR bit, and so you would have started to see a lag between what center gets in some sense through the ICMR system and what say state is getting being closer to the lab. And so these kind of things are just about how the structure of how you collect the data was organized in many of the cases, and it's simply because we don't really have a strong framework in being do that. In terms of who's responsible, I don't think there's any doubts, because the disease, the district surveillance officers and the whole teams, there's a fairly clear line of control and structure for making the data available. I think it's more a question of where the tools that were used to bring the data together more standardized, because a lot of issues also that happened were because the tool set, for example, until the center came up with this RT-PCR app, which you're probably using to now capture patient data, the initial phase, what get filled out on paper on the form that ICMR initially was using, to the time it then actually got onto the thing, there's a lot of errors started to creep in. It's just on the process details. So in many times, it's really the devil is in the details of how the process and those pieces are built at the data collection point. And you can't, look at a pandemic kind of a period to say, I'm going to put that infrastructure in place. These are things that ideally, that's not when you think of saying, okay, I'm going to start building the highway, or the highway will be available for doing this. So in some sense, we will have to do our best given the circumstances, but I think we have done actually quite well. I think I've seen some, in fact, very recently I saw the system in UP, and it's very, very impressive what UP has done in terms of trying to get accurate capture of line level data on many, many aspects of managing COVID, from surveillance, quarantines, to bed and bed management. It's actually supremely impressive in terms of how they have used technology in a state like UP to bring that into play. So I think we will see, and I'm very hopeful that not just have I seen this accelerated interest in making sure that good technology infrastructure is put in place for the country, so that we don't have to kind of deal with it. I think there is very serious commitment within government to make sure that it happens and happens on time. So I think we should all expect that, in our 2020 hindsight, we will actually learn and implement some whole bunch of practices that will actually improve how data is collected for the future.
Yeah, no, in fact, you hit the nail on the head. Like the RT-PCR app integrated with the ICMR portal is actually amazing, right? Like I said, we were also very late to the game. So, we didn't maybe deal with several of the hurdles and problems that labs who started testing, maybe early April dealt with. So when we came on board, we had this amazing home collection app on our phones. And then, this online system where everything, like each phlebotomist can literally be tracked, and it has GPS mapping. It's extreme. It's like, it's maybe too much. And, that has its own problems, but at least the vision was there, right? Somebody thought of all this. I don't know who it was, but amazing. So very, very, very impressed with it. And of course, accountability, will always be with the states, I think.
Vidhur, can I
yeah, please, Amit, please.
See, to me, there are two parts to this question, right? See, one is what Kiran mentioned. There are certain fundamental pillars that need to be in place for us to even then start looking at things. I'm not even talking about the pandemic, right? And which I know is being worked on. So a database of our facilities, a database of our doctors, a database of, the other infrastructure, and then, patient health records, right? Because if these are there, then the ability to work them through is much easier. Think about it, right? I mean, we've been building our whole universal health program over the last few years. So some of these have been work in progress. Had they been ready, we would have had a different conversation today. What gives me a lot of hope is when I see an app like Arogya Setu, which has 13 crore downloads, right? In a matter of a month. It goes out to say that digitally enabling India is not as impossible as it was earlier, where people didn't have phones or we didn't have the expertise to push them through. Now we can do a lot more with that. So at least we have the digital highway in place. I mean, one big shock which was to the system was during demo, we saw a huge uptake in digital payments, right? I mean, that is proof today that even we can leapfrog our own digital health maturity. Now, we can always do a postmortem of how well this data could have been collected today. But when I look at the way things are moving, they are moving forward. I don't think we are stuck where we were 3 to 4 months ago. We have much real-time data than what we had when this whole situation started.
And now we have stuff like the Swasth app that's just been released a couple of days ago. We'll see how that plays out. But again, it's a phenomenal move towards digitization. Telemedicine guidelines, it's now legal to do telemedicine. That in itself is a huge step forward. Taking time into consideration, we'll maybe quickly take a few more questions. Do you guys have maybe say 10-15 minutes after 5 o'clock to stick around to answer, because there's quite a few questions that have come in. Okay, Kiran doesn't. Okay, we'll figure it out. So yeah, we've covered the state part, Krishnendu, quite well. Each state does have its own issues, and data privacy also we've covered. Manpreet, who would be the owner of COVID data? The person who collates the data, the government, or the patient? I'll add that third caveat here. Who wants to take? Maybe the academic on the group can answer that question.
No, that's a hard one. So I think, yeah. So I think the third caveat that you introduced, the patient, I think, is the ultimate owner, and rest all are the custodians of the data, as per the ethical and academic guidelines. But yeah, so for COVID, this is clearly a very different situation than. Because when data-based decisions have to be taken, somebody has to assume some ownership and be able to make policies or to change policies. So I think this is a very hard one to answer, but it has to be a contract between the patient and perhaps a policymaker.
One cool nuance to this is that HIPAA and GDPR were actually relaxed for COVID data. Kiran, you want to add something? Sorry.
Yeah, no, I think the law or the policy on this is actually quite clear, right? So you are the owner of your own data, but it's never created by you; it's always co-created. So whoever is holding it is actually a data custodian who's holding it. Should not be really using it for exploitation. Since this is also a notified disease, the government has the right to actually collect and collate. There is no doubting. There's no doubting that either. I think the only question you can ask is, like I already brought up, what is the open data policy on actually making it available to a wider segment in an, anonymized format, right, where the patient identifiers are not there, which would have been useful for people like, say, Tavreet. And that's where I think the whole policy side, which is in the gray area, kind of comes into play. But I think as far as the rest of the way it's running today, I don't think there's any question on whose ownership. That's really how it is.
Got it. No, thanks for that. The next question I'm going to take is actually from my colleague Vasant. It's a little bit lower in the order, but very interesting question. Do you think that the focus of tech innovators is changing from building more efficient or, in other words, cost-effective systems to more resilient and maybe costlier systems? Since we have this subconscious bias, right? Now that there's a pandemic, what happens when there's the next pandemic? Whereas we forget that this is maybe a once in 100 years phenomena. So do you see this playing out in your own, tech circles, and where people are, trying to build more resilience than efficiency? Or any one of you three can start. I'll leave it to you guys.
It's a very loaded question, Vidhur. There are many dimensions to this. I'm presuming that this question is for healthcare and digital health companies. And the work I do with startups in healthcare, I think, look, one is, to me, this is a watershed moment for healthcare startups, right? To build something. Now, some of them are very, very contextual to what will happen right now. So many startups are being opportunistic. There are some fundamental things that are taking place. And the principles of being successful in those things that are fundamental remain the same, whether they were 5 years ago or today. I mean, you have to have a great user interface. You have to have, best-in-class technology infrastructure. You have to have a great way in which adoption or interoperability takes place, especially in an area like healthcare. So I don't see that changing. I think the other thing that has changed, in my view, is I think the global arena for healthcare has opened up in some places, and also become more relevant for domestic players in some cases. I mean, in a country like ours, I think the opening up for domestic healthcare has become much bigger, right? Now, in a tech kind of environment, my view is that you will have some players that will dominate by scale, because scale really plays, you know, the economic advantages of survival, right? And you will have a few players that will literally become larger ones than the others, and then there'll be a tail. And jury is out there, because if you look at the list of unicorns broadly, there's not even a single India-driven unicorn in health. I mean, the only one company that has crossed $1 billion valuation also services global markets. So I think it's an open field right now.
Yep. No, I think that's super duper insightful. Maybe given that we have just 5 minutes, let's take closing comments now. I think we've kind of touched upon all the other questions that are there. So I'll ask a closing question, and it's probably the most difficult question, but I would love your opinions on this. How does this end? When does this end, or does this never end? Right? Like, what will we have a new normal, or will it be somewhere in the middle? Kiran, we'll start with you, and then quick answers. You can choose to not answer.
If it go by history, it has ended in the past. You know, the Spanish flu did end. You know, even the SARS did end. Yeah. It's not. I do think there's an end. You know, but don't ask me when.
What does the data say?
So I'm pretty hopeful that there's light at the end of the tunnel. We are generating responses in the right direction. So we don't have a timeline to when it will end, but I think it's very clear that we will have better systems in place as we go forward. So hopefully, I think hopefully let's hope that we are better prepared next time, and it doesn't even arise. So that's the better hope to have.
Nice. And Amit, in case you choose to answer.
No, I would echo what Taj said. I don't think there's any ending date to this, or no expiry date to this, Vidhur. I think to me, a logical end, or if we can call it an interval point, is when we are more in control of the situation. I think that's where I think, is a logical point for us, where we know what we are dealing with, we know what is going to come in front of us, and we know how to deal with that, right? We made progress there. I think there's still more work to be done. Jury is out there when there'll be a third peak, second peak, first peak. I mean, nobody knows, right? We are dealing with something completely variable and unknown. I think it's only our response, which is becoming more and more calculated and measured, that'll, to me, is what is an interval, right?
Yeah, no, and my brother Kabir, he stays in Spain, in Valencia, and just recently I've started getting pictures of him having food in restaurants, which is which I had never thought that having food in a restaurant would be a big deal. So that is what gives me hope, right? Like, Spain was very, very bad a month and a half, 2 months ago, and now you have people going out there. Like, he recently sent a picture of him, his wife, and a friend, all three not wearing masks. I don't know whether that was right or wrong, but again, it gave hope of normalcy. I think that's a happy note to end on. Siddhartha, I would love to hear your thoughts. I know you're there lurking in the background, and then maybe we can close.
Can you hear me?
Yeah, perfectly well. Yes.
Very, very insightful discussion, and I think my take on this very interesting set of questions. Data, I think we have talked a lot about data. I think hopefully in another of these sessions, we can also touch upon the quality of the data and the way this data is being able to, we are able to triangulate it across common indicators with standardized input output. So we are able to reliably make precision-based judgment, accuracy-based judgment, and we're able to compare pockets of excellence. But I think very, very, I'd like to thank each and one of you for this very, very insightful discussion. I think the last question is the most important one. The jury is out there. But I will also say that the answer will lie somewhere in the data in the coming days and weeks and months. So hopefully we'll be there to reconvene and reflect upon what has happened here and how things have changed over the coming few months. So with those words, I would like to thank you, Dr. Vidhur, Amit, Kiran, Tav, all of you so much, and the entire audience for their questions and for their participation. Look forward to taking it forward from here. Thank you so much.
Thank you. Thanks, everyone. Thanks, guys.
Thank you, Siddharth.
Thank
Thank you.
Thank you, everyone, for
Vidhur.
attending.
Thank you, Siddharth.
Thanks. Bye.
Thank you, Kiran. Tav.
Thank you, Kiran. Bye-bye.